In this presentation, I'll be discussing the Global Pre-Hospital Trauma Care Initiative that has been developed by Dr. Dinesh Vyas and this team. So just some background information on pre-hospital care. India suffers with one of the highest mortality rates in the world. The particular problem here is the lack of pre-hospital care services. It has been determined that 80% of trauma patients in the country cannot access medical care within the first hour. In addition, there are only a few thousand trained paramedics for a population of over a billion people, and trauma outcomes are worse for rural residents as a majority of these emergency care services are concentrated in urban areas. Such issues also persist in developed nations such as the United States. The lack of accessibility results in underservice to rural areas. The heavy dependability on technology leads to a lack of appropriate response in isolated areas. For instance, the image depicted shows a general schematic of cellular coverage, shedding light on areas that are lacking. It is in these areas that roadside trauma rates are highest and can benefit the most from application of our program. Finally, there is an overall lack of capacity to address mass casualty incidents as well as non-roadside trauma incidents such as natural man-made disasters. The proposed intervention is a 2-day intensive hands-on training program that is aimed to maximally engage first responders while staying within the context of local issues. First responders have the tremendous capacity to improve outcomes for patients as they're acting during the golden period within the accident, 1 hour immediately following a traumatic incident, when patients are most responsive to medical intervention. This will help in significantly reducing the burden of the problem at hand. The program content is based upon existing trial protocols from the Pre-Hospital Trauma Life Support Group as well as the National Highway Traffic Safety Administration. Ultimately, the goal is to develop an effective, sustainable, and replicable model of education. This initiative has been in development for several years now, and Dr. Vyas has done a significant amount of work in terms of understanding the grounds for the project. He has visited several emergency departments across the country. He also visited multiple prestigious simulation centers, including ERCAD, France, and other areas with engaging high-impact educational programs already in place. Finally, he's done a lot of work in mobilizing individuals who strive to help this cause. The core components of the educational program already in place in India include instruction in the lay and native language. This is to really connect to and engage first responders. High fidelity simulation is one of the most important components of the program. The reason behind this is it allows for development of technical skill, but also a level of emotional and affective preparedness, which are really crucial for working in acute trauma settings. These are things that cannot be fostered through traditional didactic methods. We have also really emphasized collaborative learning and positive reinforcement as important educational principles for facilitative learning. We put together advanced toolkits. For example, one of the components is an airway instrumentation, which is pictured here, used to maximize the impact the first responders have on the field. We are also making sure to emphasize improvisation in management. In the case that first responders don't have access to the tools we provide them, they still must be able to stabilize the patient using commonly available resources. We've incorporated many self-learning videos as an audio-visual component, but also something that helps us transcend the language barrier. Finally, we've incorporated video debriefing as an important evaluation method. The first responders can really benefit from watching themselves perform the tasks and identify areas for improvement or areas upstream. In preparing this program, we developed a variety of aspects for the educational initiative. This includes, number one, the curriculum. Again, this is based upon pre-existing modules, and we were sure to incorporate a variety of topics ranging from hemorrhage control to fracture stabilization chest injury management, reaction stabilization, shock management, etc., in hopes of incorporating the most essential pre-hospital trauma care management concepts. We also developed a manual that can be easily referenced on the field, which has been reviewed by a variety of faculty members. We've developed intractable lecture sessions and the procedural component to go along with the didactic component for the skill sessions. Teaching techniques such as high-end simulators were also used, which is pictured on the top right. We also developed toolkits which have the highly accessible tools including the airway instrumentation and pulse oximeters. The kit also includes standard instruments such as scissors, bandages, gloves, and other basic components. This is an example of a presentation we've put together on airway and breathing management. This is a highlight of the past, current, and future program development direction, which will be elaborated later in the presentation. Here, you can appreciate a brief summary on the four-tiered educational protocol used. Essentially, the training schedule begins with a general open online course to allow for all participants to gain an understanding of the effort. As participants progress through the modules, they are taught various acute and broad trauma training, ultimately resulting in trained first responders. Here are some of the clinical topics that each level of responder is trained to perform. As you can see, the program serves to be self-sustainable, allowing for advanced trainees to recruit and teach entry-level participants. We conducted the initial session in Jodhpur, Rajasthan, which is in western India. The session was conducted at AIIMS Jodhpur with collaboration from the AIIMS Medical School, local police department, and the local administration. In general, we had support from a variety of different sectors. We trained nearly 50 first responders who came from the police department, the fire brigade, emergency services, taxi drivers, nursing staff, students, and other interested hospital staff. We recruited 18 instructors to train these individuals. These instructors were medical students, faculty, and also private practice physicians. Participants were divided up into 4 batches of 12 to 13 each, attending morning and evening sessions for 6 hours. We had 30-minute didactic or interactive discussion sessions such as the one depicted here, followed by 35 to 40 minutes of skill sessions. Here you can see first responders learning to insert a Kineldi airway. Here, first responders are shown learning to improvise a splint from commonly available resources. We also had a session on IV line placement. Here, first responders are seen learning the log roll maneuver. And here was a session in which first responders learned to improvise turning kits using a pen and strip of cloth or bandage. So the initial session garnered a significant amount of positive response. The next goal was to transition to phases 2 and 3, which involved establishing a self-sustained program in Jodhpur. The focus was on streamlining funding and streamlining administrative support to the project. Throughout this whole process, data collection was continued and participant follow-up was also conducted to assess how often and effectively the participants were using their skills, and if there is any interest in further advanced training courses. We also micromanaged the curriculum and ensured that there weren't any kinks or problems with training conducting. Finally, a multi-center initiative was established. The multi-center approach includes 6 collaborating sites, each which Dr. Vyas along with other members are regularly corresponding with. These sites are beginning to show self-sustainability and are successfully running the program objectives on their own. Covering a wide expanse or wide geographic stance allows us to understand how to tailor this program for global contexts, even outside of India, in hopes of bringing a universally applicable and flexible program model. So how does the project fare in long term? We previously discussed phase 2, We successfully completed Phase 3 by training over 5,000 first responders. This brings us to Phase 4, the global expansion. By utilizing the vast collection of data collected from our efforts in India, we can apply the training paradigm to fit the needs of rural, isolated communities across developed nations such as the United States. Within the next few years, we would like to train over 300,000 first responders among 50 sites internationally. Eventually, similar to the data collection performed in India, we can begin collecting data from established self sustainable centers across the world regarding the impact of mortality rates. Here we have highlighted some of the significant implications behind our efforts. Of note, the educational paradigm not only ensures that the participants reach a high standard of comfort and competency, but also successfully mimics real world settings. The constant feedback and real time assessment provides constant modifications in hopes of perfecting the training process. In conclusion, our objectives are to provide enhanced education for first responders. Again, these are the essential agents and can really do a lot to reduce the burden of trauma on a community. By providing high fidelity training and supplying the necessary resources, we wish for a standardized method of care delivery applicable across a broad variety of settings. We're looking to ultimately reduce local mortality rates. It is also important to identify the salient local factors that shape the trauma epidemic. These may be cultural, social, political, or economic, but this trauma epidemic is a comprehensive issue, and so we would really like to take a comprehensive approach to address all of this. Finally, our goal is to develop a self sustainable and replicable model of education that could bring about reductions in mortality across a variety of regions throughout the developing world. A global initiative to change the landscape of roadside trauma. Thank you for your time.